the guidelines address the use of effective medical therapies for patients with asymptomatic and, for intermittent claudican symptomatic PAD to prevent adverse both cardiovascular and or limb events. So can you walk us through those antiplatelet to statin to vasodilator therapies and what the guidelines state?
Absolutely. So here's the deal. As I mentioned earlier, Kim, the PAD is a very, very strong predictor of poor cardiovascular outcomes. So having a heart attack, dying, having a heart failure, those kind of things. So the first thing we want to do, whether you are symptomatic or asymptomatic, if you are diagnosed with PAD, you got to do the following. Number one, you got to have a serious lifestyle modification. So if you're eating a lot of meat and chicken, if you're eating a lot of grease and fatty food, if you don't have a Mediterranean style diet, you got to work on that. Number two, we want to encourage you to exercise. And we typically say 5 to 6 days, 30 minutes of a robust level of aerobic exercise. So either rapid walking or even some kind of a jogging or running. And we are learning more and more that the more vigorous the exercise, the more you live, the more longevity. The third one goes back to the routine stuff. So hypertension. We want your blood pressure to be less than 130 systolic and less than 80 diastolic. That's the blood pressure. The fourth is your cholesterol, is LDL. We know that LDL is the building block of atherosclerosis. Without LDL, we cannot clog our arteries. I mean, let's be honest. So we need to reduce the LDL. So we want that to be less than 70. And many of us, honestly, for ourselves and for our family members, we want it to be 30 and 40. I want my LDL to be 30 and 40. I want to be honest with you. Like that, to me, I think it's ideal to have 30 or 40. So we want to be aggressive with the statin therapy. And right now, there are a lot of therapies that are available, not only with the statins, but we have PCSK9, we have ezetimibe, we have many different drugs. And we are believing more and more that even for cholesterol, we need to do polytherapy, just like blood pressure. When patient comes to us with hypertension, we typically do maybe 2 or 3 drugs to control it, medications to control it. We are thinking that maybe the same is good approach with cholesterol, because some of these drugs like cholesterol medications can have side effects. So if you're giving a high dose, people can get muscle pain. Maybe it's better to have a lower dose of cholesterol lowering drugs like statins and then add ezetimibe on top of that, or add PCSK9 on top of that. So there's a lot of stuff which is hard to get through in an hour, but there's a lot of nuances to be able to do that. But definitely we want to get the cholesterol down. So hypertension, cholesterol. If you're smoking, there needs to be a serious conversation with your doctor. And we need to get you to a smoking cessation clinic. We need to do everything we can to help you quit smoking. And then we get to some of the other categories. These are all level 1. So that was kind of the overview of all the level 1. Then we get to some 2A and 2B recommendations. So what are some of the 2A and 2B, just to throw it out there? For example, LP(a). We know that this is a marker that has a very poor prognosis, and we think that it could be informative. So that's something that maybe we check. Now, we don't have any specific therapies for it, but there are some new novel therapies that may be coming very soon. The other one is CRP, C-reactive protein. We know it's an inflammatory marker, and it can be very useful. And there are some drugs that can reduce that. So we want to know a little bit about that. Homocysteine, another one. We used to check that a lot in the past, homocysteine. We stopped checking it because the trials were not that positive. But some people still do check it. And, some people still prescribe folate for this, folic acid. But many people don't. I mean, the guidelines didn't give it a high recommendation because the data is becoming weak. But again, once you go through the ones, but there's so many things you can do as a level 1 that you don't even need to worry about the 2As and the 2Bs, to be honest with you. But if you have done all the ones, there are some tweaks that you can do in the 2A and 2B to try to even improve the risk even a little bit more. Let me stop here, see if you think there are any questions to discuss.
I was going to mention, I'm glad you mentioned the homocysteine, because even the American Heart Association does in fact mention the MTHFR gene mutation which can lead to those high homocysteine levels. That is something that actually I have. It's also something that my dad had. I was indicated to go get, checked for it because my dad did. And what was interesting is once he realized he had this gene mutation, his dietitian put him on and he had high homocysteine, but because of it, she described homocysteine as if you have too high levels, it's like nails on your artery walls, leading to a lot of damage, which can trigger the inflammatory response and those small LDL particles eking into that damage and pushing that wall out. That's how she described it to us. And as soon as we put my dad on, therapy for that, the folate, the liposomal B vitamins underneath the tongue, his homocysteine levels significantly dropped. And it seemed to be a better outcome, and the progression of his disease, his heart disease, seemed to have stalled significantly. And this was according to his cardiologist. So I don't know what evidence or what folks they're testing, but I know, in fact, from my dad, and it's something that we have a real serious discussion with a lot of our patients about. It's that MTHFR and those homocysteine levels. So I'm a firm believer in that, just based on my own experience.
Absolutely. So there are other, and that's again goes back to the earlier conversation we had that, there's a lot of pressure in medicine, Kim, to see patients quickly. If you're saying, if you're, we are supposed to see patients in 10 minutes, 15 minutes. And you can imagine, we look at this discussion, there is so many things, there's so many nuances, there's so many opportunities. So, you need sophisticated doctors that can delineate all these other opportunities, but also not to forget about the low-hanging fruit, because again, it is nice to deal with the homocysteine and Lp(a) and CRP and some of these other more advanced risk factors, but just the basic stuff is still not being done. So we need to really work together in trying to educate our patients that they demand that, listen, what is my LDL? Why isn't it not 60? What can I do to get my LDL to 60? Because there are some doctors out there that they're still practice with LDLs of 100 and 120 and 130. So the more that our patients are informed, the more they can demand and ask questions. And that's why I do these webinars, to be honest with you, because I am very passionate in educating our patients. I think we have to empower our patients to seek the best care that they can get.
I just wish that the guidelines would have included a little bit more definitive in terms, recommendations in terms of if you have a patient that's ending up with a revolving door of treatments, that it's a requirement that the doctors sit back and there should be a checklist of all of these, even level 2 and beyond, to say, okay, we checked this, we did this, we checked this, we did this. Okay, we need to go to the next levels to find out why is this revolving door of treatments continuing and continuing. We got to get to a deeper level, because there are a lot of patients out there that are the exceptions, in a sense, to the rule.
Absolutely. Absolutely. And unfortunately, this comes all down to execution, right? It's all nice that we have the guidelines, we need it. It's nice that we have the data. It's nice that we do all these clinical trials and we spend millions of dollars learning and identifying what works and what doesn't work. But at the end of the day, if we don't do the execution and deliver this to our patients, either because the drugs are too expensive or because somebody didn't have these conversations with our patients and didn't do the checklist, or because our patients didn't do the drugs because they're too complicated, and they forget to do it, then we didn't do our job. So there's a lot of resources that goes to getting all the information, but at the end, it's all about execution and making sure that, we are bringing all these therapies and all these opportunities to our patients.
And one that I didn't hear you mention, the vasodilators, the platelets. I know that they have been in Society for Vascular Surgery guidelines. Are they in these guidelines to talk about the use of those types of drugs?
Yeah, the plitol is a little bit tricky. So the plitol, as you know, we prescribe it only for symptomatic P.A.D. And plitol gets a good recommendation, a class 1 recommendation, because there is some data that if you have symptomatic P.A.D., not asymptomatic, symptomatic P.A.D., that, it can improve your walking distance. The problem with Plital is that it has a lot of side effects. It's contraindicated in patients with heart failure. It can also cause a lot of GI upsetness. It needs to be titrated up slowly so that patients don't get side effect from it. My own personal experience with this drug has not been great, to be honest with you. I do have a good number of patients that are taking it, don't get me wrong, but it's not the holy grail. Unfortunately, because we don't have too many drugs, we are stuck with it, and this is the only one that we have. So we use it, we talk about it a lot, and in the guidelines, it gets a class 1 recommendation, but the reality is that it's not a very effective drug. The one thing that maybe we should emphasize is also supervised exercise therapy for PAD. And I think that one is a very huge one. And I think that every patient that has symptomatic PAD should be getting supervised exercise program for PAD, in addition to aggressive medical therapy and revascularization. Symptomatic.